Covered that last week. What we're looking for with double contrast. Mucosal lining, right? So we're looking for mucosal lining. The problem with solid column is you're just not going to see mucosal lining very well. You're going to fill the colon up, and the barium is going to be so hard to penetrate that if you've got diverticular or any kind of mucosal defect on the opposite side, or even on the, you know, if the patient's AP, if it's on top or bottom, all you're going to see is barium. So you might see it on the sides, but otherwise you're not going to see it. We see a lot of diverticula in the colon. We see quite a bit of colitis in the colon. So we need to see that mucosal lining well. So in a lot of cases, we're going to be doing double contrast. So with double contrast, what that often will call for is the radiologist or the PA will fill the patient up under fluoro, maybe take some overheads, and then take the enema bag and put it below the tabletop level and open the valve back up and let it flow back into the enema bag. All right? So you're not going to completely evacuate the patient's bowels by doing that. The coating on the bowel is going to remain, and then they'll inflate the colon with air after that to separate everything out so that we can see the mucosal lining. So what we did with solid column, we're going to do with air contrast, but we're going to do opposite views as well. So everything that we did for solid column, we're going to do the exact opposite for those, plus the exact opposite for double contrast. So again, we're going to do the AP, we're going to do the LPO, we're going to do the RPO, maybe a AP sigmoid of some sort of lateral. We're not going to do two laterals most likely, but we are going to do also some obliques, okay? So we're going to do the APs, and then we're going to turn around and do PAs. Now again, on your test questions, think gravity and read the question well to determine what it is it's asking you. Where is the barium versus where is the air, right? If it's asking you for mucosal lining, that's always going to be air, right? So if we shoot AP, right, so we fill the patient's colon with barium, empty the barium, and fill it with air, then for the AP oblique, well, first off, the AP, where's the air going to be? It's going to be up, right? So what part of the colon is up? Transverse colon, right? So the barium is going to be in the ascending, descending colon, and the air is going to be in transverse colon, right? So LPO, where is the air going to be? Yeah, right colic, hepatic flexure. Barium is going to be down. Splenic flexure, right? RPO is going to be in the splenic flexure. The air is going to be in splenic flexure. The contrast is going to be in the hepatic flexure, right? Let's flip it around. So we got PA, right? So where's the air going to be in a PA projection? No rotation, just PA projection. In the ascending and descending colons, right? Where's barium going to be? Transverse colon, right? So now we've got LAO. Now where's it going to be? Kind of look like more like this. Where's it going to be? What's on the left side? Here. Oh, make it look more like that, so it doesn't look quite as confusing. That's going to be the splenic flexure, right? RAO is going to be the hepatic flexure, right? So everything is exactly opposite, right? So we had LPO. LPO gave us the hepatic flexure, right? But now the RAO is going to give us the hepatic flexure. LAO is going to give us the splenic flexure. RPO gave us splenic flexure. Okay? All right? You kind of following along? Okay. All right. So lateral is going to be lateral. You know, again, maybe cross table lateral, maybe the last image that you shoot. AP axial, you may do PA axial as well. We just talked about those. The complication comes with the DQs. Where are the DQs? Okay, I'll have them on there. All right. So what you're going to do with double contrast exams also is going to be a left lateral decubitus and a right lateral decubitus. All right. So with left lateral decubitus, your test questions are going to be really tricky with these. Okay. If you're looking for the mucosal lining, you put the patient on the left-hand side. Where's the contrast going to be? You got to think gravity, right? And you got to think that every portion of the colon is probably going to have some degree of barium still left in it. Okay, it's going to be pooling, but where is it going to be pooling? Down, right. So the air is going to be up, right? So what we're going to see then is, I can do this. You're going to see the patient's on the left-hand side, so this is going to be descending colon, right? So you're going to see the medial side of the descending colon, okay? Lateral side of the ascending colon. The patient on the left-hand side. You got me?
Most of the air is going to be on the lateral side of the ascending.
Lateral side of the ascending colon, medial side of the descending colon. Okay, now you flip the patient around like this. They're in a right lateral decubitus. Right? Where's the air going to be? It's going to be in the medial side of the ascending colon. It's going to be in the lateral side of the descending colon. Okay, take it one step at a time. Just kind of lean, you know, while you're taking the test. Just lean and, you know, kind of try to figure it out, right? Most complicated portion of the test is where's the barium going to be on your decubitus. So most complicated portion of the exam is also going to be that. All right, so where you could get away with making the patient make a single rotation for your solid column, the patient's pretty much going to have to turn over twice for your DQ, for your air contrast. Okay, so you got all the projections. You got AP, LPO, RPO, maybe a lateral, RAO, PA axial, LAO, and then decubitus, and rotate all the way back around for another decubitus. Okay, so the bad news is, you know, you're gonna have to rotate the patient twice in order to get all that stuff. The good news is, most of the time, if somebody's gonna lose the contrast, it's gonna be on a single contrast exam than what it is on double contrast. Okay, so tend to be less messy. All right. All right. Any questions on it? So then what we're going to see is mucosal lining. So over here we've got of the two flexures, we've got this one significantly lower. Just understand that, you know, this is a PA. You can tell that it's not got a whole lot of rotation because our spinous process is in the center of our spine. But the right colic flexure looks like it's pretty well open. Okay, so don't let the appearance of the colon itself, you know, make you think that it's something that it's not on your film evaluation down in the lab. Okay, so air contrast, you can see the mucosal lining pretty well. You can see these little pouches right here. That's diverticulum. All right. So PA axial. You know, they say it opens up the sigmoid colon. It still looks like an awful lot of superimposition to me. It's just a mess. Okay, so RAO. We've got RAO, we've got an open hepatic flexure, and this over here is just a jumbled mess. Is this a problem that we didn't get the top of this?
No.
Answer is no. This is primarily what we're looking for right here. right? So LAO, is this a problem that we didn't get the top of that? Yeah, you should have gotten that, right? It's kind of interesting. We see the appendix down here. Filling of the appendix is not uncommon on BEs. All right, so lateral rectum, again, they may ask for cross-table lateral with the enema tip deflated and out. And that's a registry testable question. They're looking for pathology in the retrorectal space. Okay, so just file that away. You may see it on the registry. Okay, so apiaxial, again, just a big jumbled mess down there. All right, so let's get to pathologies. Oh, decubitus. So there's decubitus. When you're looking at your images in lab, remember that your splenic flexure is going to be higher, right, than your hepatic flexure. So this will be right lateral, right? We can tell it's right lateral because where the contrast is always going to go to the lowest level, right? So what we're looking for here on this decubitus is the lateral side of the descending colon. We can tell that's descending colon because that's splenic flexure. We can tell that's splenic flexure because it's higher than the hepatic flexure, right? So we're looking for the air contrast on the medial side of the ascending colon and the lateral side of the descending colon. And the exact opposite here, we've got the splenic flexure, much higher in this case than what is the hepatic flexure. So we're looking for air in the lateral side of the ascending colon and the medial side of the descending colon. So common pathologies, what we see are diverticulum more than anything else. If you suspect the patient has any one of these, if that's the concern, that definitely needs to be communicated to the radiologist. If they've got cancer, it may be pre-op, and if it's pre-op, they're going to want to do gastrography. If it's just diagnosis and they intend to try to shrink the tumor, then it's probably going to be barium. Volvulus, intussusception, there's a good chance that either one of these patients go to surgery, so we'll talk about those here in a second. So intussusception is usually secondary in adults. It's secondary to some other pathology. And let's see, dryer vents. Everybody know what a dryer vent looks like, right? A dryer vent, you straighten it out and it goes, right? But you can mash it together and it kind of scrunches up. That's kind of the appearance that you're going to get off of intussusception. So this is not small intestine, even though it kind of looks like small intestine. Actually, it may be small intestine, but it's going to give you a cold spring appearance. A better analogy to what intussusception is you ever seen those cups or bowls that are completely collapsible? Some people take them camping. Okay, intussusception. All right, so it's where a portion of the bowel pushes into another portion of the bowel. And in adults, it's again secondary to maybe a cancer, something like that. So you've already got a weakened condition in the bowel. But the issue with intussusception is not the presence of intussusception, but what's going on with it, right? So you've got blood vessels going all the way up and down through your colon, right? And if you take a portion of the bowel and you mash it into another one, if you got blood vessel that's going this way, and you take that portion of the colon and you push it into another one, now that blood vessel is going that way, followed by that way, followed by that way. Ever taken a water hose and bent it twice and pinched it together? What happens to the water? And go, right? Now apply that to blood vessels. What do blood vessels do? Supply nutrients and keep your body living, right? So you pinch it off twice, and what's going to happen to it eventually? It's going to die, right? So if they get these patients in quickly enough, they can reduce the intussusception just by increasing the pressure. Just having the exam may cause it to pop back up. Happens in kids. It's what we call idiopathic. We don't know why it happens. It's not going to be secondary to to any kind of pathology, but in adults it tends to be secondary, probably to cancer. Okay, so intussusception, and it gives us a coil spring sign. Volvulus is kind of like, well, it's twisting of the bowel. And you would expect, the first time you go to surgery and you see any kind of abdominal surgery, you would expect every single time that they do abdominal surgery, the patient would have volvulus. Body is a fascinating thing. You know, they do a surgery on a patient, and they'll take all the intestines and they'll pull them out, and they'll set them, you know, just on the patient's abdomen and go to work inside the patient. And when they're done, they just scoop them inside and sew them up. And they find their own spot. It's amazing. But once in a while, again, for whatever reason, sometimes we'll get a twisting. Okay, so now imagine that you're doing the twisty balloons, you know, somebody's making balloon shapes, right? So they blow a balloon up part way and they push the air down into the bottom of the balloon and they twist it, and then they make something else, right? Why does the air stay where it's supposed to be in those twisted up animals?
Pinched off.
Because it's pinched off, right? So you got a bowel that's doing the same thing, and again, you're going to have a situation where you've got compromised blood flow. At best, you got a bowel obstruction, right? Nothing can go through there. But you might also have, you know, some compromised blood flow, eventually leading to something, you know, like a necrotic bowel. So volvulus, twisting. And they call it a bird's beak sign. That's doesn't really look like a bird's beak to me, but okay. All right, so ticks we looked at, some other things that we might see. Sometimes we may see, you know, most of the time we're not going to do a barium enema for this, but if a patient has appendicitis, then the appendix, you saw the appearance of the appendix being just a nice fine line, right? If the patient has appendicitis, it might be big and puffy, so it might be visualized. Worked in a hospital where it was kind of routine to do a gastrographic enema on a patient who had appendicitis. So you may see that. Colitis. Colitis, in a lot of cases, what you see with colitis in the large bowel, you see the haustral markings, the big, you know, clumpy, looks like Marshmallow Man, right? Michelin Man, whatever, right? It's big pouches. With colitis, what you get is a loss of that, and some references will call it a stovepipe colon. So it's just smooth, completely lacking of those markings. And sometimes it could be, you know, because of pathologic conditions. Sometimes it's because of overusage of laxatives. Okay, so you may see a patient who just doesn't have any haustral markings at all, and that's colitis. Okay.